So we have with us tonight Dr. Jan-Karl Burkhardt, and he is a cerebrovascular surgeon. I'm going to wind up reading this. He's a cerebrovascular surgeon and an assistant professor in the Department of Neurosurgery and Neuroradiology at the University of Pennsylvania. His training includes residency at the University of Zurich, where he trained under Dr. Helmut Bertalanffy, who is familiar to many of you. And he additionally had fellowships at NYU and at UCSF. And at UCSF, he trained under Dr. Michael Lawton. Dr. Burkhardt is the co-author of 147 peer-reviewed papers and has a special interest in cerebral cavernous malformations. He's looking forward to developing the Penn Medicine as a CCM Center of Excellence and to expanding his research, working collaboratively with Dr. Mark Kahn's team. So welcome, Dr. Burkhardt, and please take it away.
Thank you, Connie, so much for the invitation and the kind introduction words. I'm really honored to talk today a little bit about CCM clinical decision-making. But before I start, so this is kind of the structure of my presentation today. I want to give also a quick introduction. Connie, you covered most of it already, but I want to show you a few images about my background, how I came to CCM, to the passion to treat these lesions and also try to improve treatments every day. And then in the second part, I'm going to talk a little bit general about cavernomas, epidemiology, types, and different treatment options. And then I'll show a few examples and go more into the clinical decision-making process when I think it's a good indication for microsurgery or other treatment modalities and where we should probably just observe. So let me get started. So I'm from Freiburg. As you can hear, my accent is pretty strong. So I'm from Germany, but if you see the scenery here, that looks pretty familiar to me here outside Philadelphia, where we live. And then I went to medical school in Leipzig, one of the largest medical schools in Germany. And as mentioned, I then began my neurosurgery residency in Zurich. One of the reasons why I went there was because Professor Bertalanffy during that time started in Zurich, and he was known for his skills in skull base and also brainstem surgery. So I was exposed to cavernomas very early in my career. And actually, when I left Zurich later, I realized that it's not that common brainstem cavernomas because he treated nearly every week a brainstem cavernoma. I did also a lot of research in Zurich, clinically, but also in a lab. That's one of the papers we published during the time. And then after my residency, I went to the US. My wife is from the US, she's from New York. So we made the decision to move to the US, and I had the opportunity to be the clinical fellow in 2016 with Michael Lawton at UCSF. He probably doesn't need an introduction. He's very innovative, especially in the field of cavernomas. He's very well published, has multiple books published. And as you can see here, he published about arteriovenous malformations, aneurysms, and bypasses. And he's currently working on a new book about cavernomas, so that should come out pretty soon. I'm very excited about that. He developed new techniques, new instruments for surgery, specifically for cavernomas. And then after my endovascular fellowship in New York, I started at Baylor in Houston. And I had really a very good relationship with the Texas community from Angioma Alliance. And it was very welcomed by Lexi and all the others. And I really enjoyed being with them and helping out or advising as needed. And then my chair from Baylor, actually, after I was just 2 years at Baylor, had the chance to be chair here at Penn. And when he asked me to come with, obviously for my wife, she's from New York, to be closer to home, that was a factor, but also we all know that Mark Hahn is one of the top leaders in the world in research for cavernous, and that gave me really the opportunity to kind of combine my clinical practice and interest in cavernomas with his research efforts to make really in Philadelphia an impact on treatment and research for cavernous. And here you can see our neurosurgery team down here, the clinical team, and here the lab from Mark Hahn. And this is our new hospital, which we will open in October. So let me talk a little bit about cavernomas. I hope the information is adequate. I know that some of you are probably just diagnosed with a cavernoma, so hopefully this information is helpful, and others know already a lot about it. It may be a little bit boring. Overall, these cavernomas are very rare. As you can see, the incidence is only about 1 per 100,000 per year. And if you look at the diagnosis by age, when patients are diagnosed with a cavernoma, you can see that most of the patients are under 40 before the first diagnosis. And overall, it's only 10 to 15% of all vascular lesions in the brain, and they can be familiar or sporadic, and in 20% roughly they are familiar. And there are different locations where you can find these cavernomas in the brain. Most commonly, they are in the hemispheres, as you can see here, called that supratentorial. And in a smaller portion, they are located in the brainstem, as you can see here, or in the cerebellum in 15%, and even less common in the spinal cord. The pathophysiology, I don't want to go too much into detail, but I try to illustrate this here a little bit so you can see here first how the perfusion in the brain works. So there are large arteries who are then becoming smaller and smaller and create this capillary system for exchange of oxygen and other things. And then on the other side, building up larger veins back to the heart and lung. And the cavernomas are really a disease of the capillaries, as you can see here. And as the name says, they are clusters of abnormal and wide little caverns, as you can see here. And there are some factors missing. Smooth muscle cells, tight junctions can be damaged, and that causes the appearance of this cavernoma. People call it sometimes also mulberry-like, as you can see here. And this is a specimen, actually a specimen still from Zurich, from Helmut Bettelanff. He removed it from a brainstem cavernoma. And this is how it looks then microscopically. So you see there are some areas, so the yellow areas are hemosiderin, and you can see how these lesions, they are not really a classic hemorrhage, but they more ooze because of the loose tight junctions in these cells. How do patients present with cavernous? It is interesting that a lot of patients actually have no symptoms. So we call that incidental. So you get in CT scan, for example, or MRI for different reasons. For example, you have a head trauma, you had an accident, and then we find a lesion. That's a very common finding. So it's possible you have no clinical symptoms, or also very common, you may have a hemorrhage or neurological deficits, depending where the lesion is located. And also a very common presentation is seizure. And you can see here the risk of seizure. And there is actually, unfortunately, a high chance of chronic or drug-resistant epilepsy with the seizure of the cavernoma. The hemorrhagic risk, as you can see here, is about 2.6 to 3% per year. Is a little bit higher in females than in males. And also the rehemorrhage rate in brainstem cavernomas is also a little bit higher, as you can see here, 17 versus 11. I think the brainstem, since it's such a delicate location, even the smallest increase of hemorrhage can cause a more severe deficit. So it's more noticeable than in other locations. What is the best diagnosis for a cavernoma? As you can see here, this is a CT scan. The CT scan is not very sensitive, but you can diagnose a hemorrhage, as you can see here. So the hemorrhage is this white structure here. The gray area is the parenchyma, and the outside, the white, is the bone. So it's useful to see, oh, there is a hemorrhage, but you can't really see if this is a cavernoma. A catheter angiogram, where we, similar to a heart catheter, where we would introduce a small catheter and take selective images of all the vessels in the brain, won't show anything either, because these lesions are so low flow, as I mentioned before, in the capillary phase, that these appear angiographically occult. And that was actually one of the descriptions before they were grouped as cavernomas. They were called angiographic occult lesions. And this was one of the first publications. Because what happened was that on the angiogram, they couldn't find it, but on the CT scan, they saw a lesion, and intraoperatively, they found the cavernoma. So the MRI is the most sensitive study to diagnose these lesions, as you can see here. And they're most of the time, they have an appearance of popcorn. So that's why it's like popcorn appearance is often mentioned. And there are different specific sequences who are better for CavMels and for screening than others, as you can see here. For example, the T2 star sequence or the SWI. And these are very specific sequences, and they can pick up also smaller lesions, which are important for multiple cavernomas or for the familiar type. There are different grading systems. I don't want to go too much into detail, but here this is a grading system from Dr. Zabramsky from BNI, where you basically can predict which lesions are more likely going to bleed or rebleed. And that can be very useful in the clinical setting. So besides the MRI, what we're always looking at when we find a lesion, if there is a so-called DVA, a developmental venous anomaly, associated with the cavernoma, and they're more common in the sporadic form than in the familiar type, and appear in 8 to 33% on average. But it also depends a little bit what type of imaging modality you have. So these are high sensitive imaging 7 Tesla MRIs. So usually we use a 1.5 or 3 Tesla. And the higher the resolution, you actually see that nearly all of the cavernomas actually have a DVA if you would use a 7 Tesla, which nobody has. But in this nice study from Essen, from Germany, they found actually that nearly all patients have a DVA if you go higher in the resolution of the MRI technology. What type of types exist for cavernomas? We usually differentiate between the familiar type, but as I mentioned before, 20% of these patients are in this group, and the sporadic form. The sporadic form is a de novo formation. It's a single lesion and has usually a visible DVA in the low resolution MRIs. And the familiar type, they're different genes, and I'm sure Mark Hahn gave a webinar about about these details, so I'm not going to cover much, but I quickly want to mention there are different genes involved in the disease process. And then there's also radiation-induced type. So for example, patient who had treatment as a child, radiation treatment, we see quite often patients in clinic who have then 10, 20 years later a cavernoma after radiation. So what treatment options do we have? And I kind of want to illustrate with this picture that it's really important to find a specialized center to discuss what is the best in my individual situation, and find a team that you trust and where you can really ask all your questions and discuss all the options for you specifically. And then the good thing is with cavernomas, most of the time you have time to decide. It's not an emergency. There can be in rare situations, but I would always recommend to take your time and think about it. These slides is a little bit, it's a lot of text, as you can see here, but for people who are interested, these guidelines are pretty interesting. For these tables cover basically recommendations for screenings when would you screen patients for the familiar type genetic testing, and also what imaging and in which situation you would recommend an imaging modality, and then also the medical treatment, what kind of medication would you recommend in which situation, and also last but not least, the surgical indications, when would you recommend surgery. I summarized this a little bit in this graph, and that's also kind of my treatment regimen, how I think about it. So as I mentioned, it's rarely an emergency, and in patients who are clinically stable or have no symptoms, you can really go with a wait and see policy. And then you really have two options. So either observation or treatment. And observation means a clinical follow-up with serial imaging, most of the time MRI. Usually what we do is a short interval. If you diagnosed with a new cavernoma, can be 3 or 6 months the first time, and then you can increase to a year or even 2 years. And the observation applies to small asymptomatic lesions. For treatment, the mainstone nowadays still of treatment is microsurgery, but hopefully in the future, depending on our research, medical therapy may be available. Right now there are clinical trials, but not established therapy. And then in some situations, if they're in a deep location, laser surgery, so-called LIT, can be applied, or in very, very rare cases, also radiosurgery. But with radiosurgery, we always have to be careful because, as I mentioned before, they can also cause cavernomas. So we are usually not recommending radiosurgery, only if it's a very last resort. For microsurgery, I like to make a subgroup division here in accessible lesion and less accessible. So accessible for me means they're superficial, you can reach them easily with surgery, and less accessible are more deeper lesions, let's say in the brainstem or in areas where it's very eloquent. And usually our way of thinking is, if it's in an accessible area and you have a symptomatic hemorrhage with your cavernoma, or a deficit or seizure, first-time seizure, or a lesion progression with mass effect, then it's very reasonable to offer surgery early and cure the patient from the disease. But if it's less accessible in the brainstem especially, we usually wait if there's a hemorrhage, and we let the patient recover, and only if there's a second event of a hemorrhage, then we would recommend surgery, because the morbidity of the surgery itself has also risk, and you can also make it worse. So that's why we're having a more careful approach in these more eloquent areas. I want to show you a few tools for surgery. So what we use, so when we decide to do surgery, what are the instruments we have? And the most important instrument is our microscope, as you can see here. So we do all our surgeries nowadays with a microscope. And so you can see me here operating, and so you see that I use both of my hands, but these microscopes nowadays have also a mouthpiece where you can move the microscope, so you don't have to use your hand to move the microscope while you're operating. So these are very innovations over the last couple of years, make it very safe for surgery. Also, we use a lot of different microsurgical instruments for technique, and I just wanted to illustrate how we usually remove a cavernoma. This is now a lesion on the surface, and we have different instruments, a so-called bipolar forceps, where we can coagulate an area and then also later cut. And this is a suction device. And then we walk our way around the lesion, as you can see here, and remove the lesion. Besides the micro instruments and the microscope, we have also other tools in the OR nowadays. So one very important thing is the navigation. As you can see here, an example from BrainLab, there are different companies, and you can hook up this navigation on instruments or also on your microscope. And that kind of shows you while you do the surgery on a screen where you are based on your previous imaging on MRI. So that's very helpful, especially for cavernomas who are a little bit deeper, to find the correct trajectory and to know where you are. And this also includes intraoperative imaging. A very simple intraoperative imaging modality is ultrasound, as you can see on this screen here illustrated. So you can do during the surgery, you can acquire a live image, because the disadvantage of the regular navigation I showed you before relies just on the preoperative imaging. But if you're in surgery, then sometimes the brain can shift a little bit, so it's not as accurate anymore. But with the ultrasound or these newer devices who can then use the ultrasound technology and overlay the previous images, can really nicely show you where you are, and can be also used for resection control. So after you remove the cavernoma, you can make sure it's all out. Then another very important tool for surgery for us is the intraoperative electrophysiology. So what we do routinely on all of our patients is so-called SSEP and MEP monitoring, where we have a specialized team. You can see them here. They apply small needles when the patient is asleep, and we can monitor and can make sure that all these fibers are working during the surgery. And if there's a change during the surgery, then we can stop the surgery, or can see why there was a change. And so that's very important to know during the surgery when the patient's asleep, that we know the function is working. In some specific situation, when a lesion is close to a language area, we can also perform surgeries awake, and then we can map on the surface of the brain and stimulate the brain while the patient is communicating with us, to make sure that it's safe to go through a specific area. So that's also sometimes necessary. Okay, let me show you a few examples. So this is the first patient I want to show you. It's a 62-year-old female patient, and she has an incidental finding during workup for neck pain. And as you can see here, there is a lesion. This is here the brainstem, and you can see that there's this popcorn-like appearance structure in the brainstem. Also here you can see the lesion, and here also on the side, it's in the pons. And this is a highly eloquent area where the motor function is located. And you can see that the lesion is not really coming on the surface, and the patient has no neurological deficit. So this is really a location where we would not offer any invasive treatment, because you would potentially make it worse, since there's no deficit and it's in a highly eloquent area. So this is a patient where we would recommend observation. So if this is a new diagnosis, I would probably recommend in 3 to 6 months to do another MRI and then see if there are any changes, or obviously if there are any clinical changes, then we would see the patient right away. Another patient, as you can see here, with a lot of multiple small spots, also asymptomatic. This is also a patient, although there are so many lesions, we would definitely recommend observation if there's no deficit. Patients who have multiple cavernomas, we sometimes have to perform multiple surgeries, but only if really a lesion enlarges significantly or becomes symptomatic. So this is not a situation where you recommend to treating all these asymptomatic lesions. This patient, on the other hand, is a young patient with previously multiple Cavernous surgeries. And this is the scan a year ago. And then you can see within a year, this lesion formed here in the temporal lobe. And he had also a new deficit, so a new seizure. And it's on the surface. So this is really a situation where we would recommend surgery, because it wasn't there a year before, and it's symptomatic, and it's a young patient and very accessible. So here we recommended microsurgical resection. And you can see here with just a very small incision, because the lesion is also not very large, you can treat this patient. And these are intraoperative images. This is how a cavernoma looks like when it's on the surface. You see all the yellow changes. That's the hemosiderin. And here you can see healthy brain tissue in comparison to the hemosiderin. And this is the cavernoma when it's out. This is how it looks. And this is the post-op MRI for resection control. This image you remember from a few previous slides. In this patient, this is a 60-year-old female patient, and she presented with an ICH, with an intracranial hemorrhage, as you can see here on the axial scan here and here. And her symptoms were aphasia, so she had trouble speaking because it's on the left side. That's her dominant hemisphere, so it's very common with the hemorrhage in this location to have these findings. And she had also weakness of the contralateral side, so the right side was weak, which also matches with the hemorrhage. So as I previously discussed, so the CT scan helps us to show a hemorrhage, but the MRI really helps us then to define the lesion. And here you can really see that this is all a cavernoma here in this area, and this structure here is actually hemorrhage. And here you can also see really the lesion nicely on the MRI. So this is obviously also a situation where we would recommend treatment. She's symptomatic, she has a hemorrhage, and it's in a location where we can safely operate. So in this situation, the approach was to open the so-called Sylvian fissure, which is the connection between the frontal lobe here, as you can see in the illustration, and the temporal lobe of the brain. And you can just open the space in between here without going through any brain tissue, as you can see here. So this is the frontal lobe and the temporal lobe. And then here at the bottom with image guidance, as I showed you before, the navigation confirmed that this is the right location, also with ultrasound. And then I was able to just open a little bit in this area, and then we saw the cavernoma right away here, and were then able to remove it completely. And this is the final overview then after the resection. And you can see that we're not going through any healthy brain tissue. We're just opening the spaces between the two lobes and find really the spot where the cavernoma is located. And here you can see on the post-op scan the route we took. Here on the other side where we didn't operate, you can see the Sylvian fissure. So this is the black area. And that's just an area which is filled with fluid, and you can open this area, and this is the resection cavity. In this sequence, it's a different color. It's white, as you can see here, and this is the resection cavity. I want to show you one more patient. This is a 50-year-old patient. She also presented with a new seizure and also lesion progression, especially on this sequence. You can see that there was a little bit of more hemorrhage. I don't have the comparison, but the lesion was smaller a year before, and now she has also a deficit, a new deficit. So we decided also to offer microsurgical resection. Here, I just want to highlight different surgical techniques. You don't have to remember this in detail, but the bottom line here is that we really use these spaces and gravity retraction during surgery to avoid going through healthy tissue. And we really use these corridors. And in this situation, it was actually very favorable to come from the other side and to find the lesion on the contralateral side, because it basically falls into your view. I'm going to demonstrate this here on a few pictures. So you can see here, this is the frontal lobe, and this is the falx in between the frontal lobe on the right side and here on the left side. And also the advantage is the left hemisphere is usually the dominant hemisphere. And so if you come from the right side, you avoid complications of the more dominant hemisphere where language is located. So in this situation, it worked out perfectly because we came from the right side and made our way all the way down. And then we found the lesion, as you can see here, very close to the anterior cerebral artery, who was like running right over it. So we had to be very careful. And then I was able to dissect it nicely out, and the lesion, and remove the lesion in total, and obviously leave the anterior cerebral artery intact. And that was then the final view. But you can really see nicely how during surgery, the lesion is coming into your view. instead of retracting on your side. And you basically use the gravity retraction, as you can see here on this picture. And so you see that the lesion is resected here, and there's no corridor where we went through any brain tissue. So we really only use the spaces who are already there. This is a similar concept for lesions in the brainstem. So if you want to access an area very centrally, you can also go on top of the cerebellum by opening up this arachnoid space and use then gravity retraction to get to this area. And this is an example of a very centrally located lesion. But if you think about this concept and you come from here, then you don't have to go through any healthy brain tissue to get to the lesion. And this is the intraoperative view where you see this is the cerebellum after opening here the space without injuring any brain tissue. You can really safely reach the lesion here. And after resection, you can see this is the corridor I used to get there without going through the cerebellum or other corridors. So in summary, I hope I showed you on these on these different situations that conservative treatment is really the way to go for asymptomatic single or multiple lesions, and that we offer surgery for symptomatic lesions, for hemorrhage, or for growth over time if the location is accessible. If it's very deep or eloquent located, then we usually wait for recurrent symptoms or for a second hemorrhagic event. And it's very important for us to really look at the approach and safety entry zones from a technical perspective to make it very safe for our patients. There are different other things we should consider, also workup for epilepsy for patients who have already who have this for a longer time, and then also define really the resection, extent of resection based on the workup, because that's what I didn't mention in my presentation is the hemosiderin can also cause sometimes seizures. So if the cavernoma is in a location where there's no function in the brain, then we are usually very we extend our resection to remove really the hemosiderin, so the blood, because that can still irritate although you resect the lesion. In obviously very high eloquent lesions in the brainstem, for example, we're not gonna chase down the hemosiderin because that increases more deficits after the surgery. And then medical therapy, we're very hopeful, especially in patients with multiple lesions or in patients who have just mild symptoms, that we can stabilize the disease or also regress the disease. Yeah, thank you very much. I also want to thank my research fellow, Mohammed Salem, who helped me to put some of the slides together. Now I'm open for questions.
Okay.
If there are any.
Yes, thank you. That was wonderful. We have a number, and I have a feeling more are going to be coming in. The first questions are, I'm going to ask you are a little bit of asking clarification on mostly some of the numbers that you showed. So the hemorrhage rates that you indicated, I think I remember them as being 17% in brainstem and 11% in supratentorial lesions. I may not have that right, but the question was, is that the rate for those who have never had a bleed? And if so, is the hemorrhage risk higher if you have had a previous bleed?
No, so these numbers were when you had a previous hemorrhage. So once you had one hemorrhage, the risk that you have another hemorrhage is unfortunately a little bit higher than in patients who never had a hemorrhage. So that's why we would offer, if you have your first hemorrhage and you're diagnosed with a hemorrhage and it's in a location where we can safely operate, then we would always prefer this initially. But in locations like the brainstem, we would not necessarily recommend to operate like the first surgery, because it's still a better chance for the patient to recover without the surgery. And only if we see that it's a dynamic lesion and it causes another hemorrhage, then we would offer.
Okay. All right. And then the next clarification is just on incidence. The person starts with excellent presentation. Thank you. I thought that with improved imaging, that incidence of CCM is more like 0.5%. So that was 1 in 200, not as rare as you state. Do you think that's true?
Yeah, I think that's true because he or she's correct that the better our imaging modalities are, the more lesions we're going to find. And we're doing more and more screening. And it's the same also with other vascular lesions in the brain, with aneurysms, for example, that we find more and more smaller aneurysms. So that's possible.
Okay. And then the next question is, again, a clarification of something that you said. You had mentioned that children that have radiation for angioma usually have another bleed 20 years from then. And I think that
No.
needs a lot of clarification.
No. So what I meant was patients who had, for example, a brain tumor as a child and received radiation. And 20 years ago, the radiation was more unselective than nowadays. So nowadays we can really do a focused radiation for patients with cancer in the brain. And so unfortunately, the patients who had the treatment 20 years ago are still presenting late with formations of cavernomas. So these patients didn't have cavernomas in the first place. They had a different a tumor and were treated for that. And the consequence from the treatment modality, from the radiosurgery, caused then later in life a cavernoma. That's what I meant.
Okay. All right. So someone is asking, when is growth of a lesion concerning versus when is it just normal growth?
That's a very good question. So if it's really like we are comparing images, and sometimes there's obviously also a little bit of an error if you look at pictures and measure it. That's why radiology is measuring these lesions usually, specifically on their workstations. I would say a tiny bit of growth is probably normal, but it's also possible in cavernomas that they sometimes shrink a little bit. So plus minus, if it looks similar, then I think it's no additional symptoms, no edema. So edema means swelling that we see on the MRI, additional factors that the lesion may cause mass effect on the brain. Then I think it's safe to observe. But if even a small growth is associated with a new symptom or with mass effect, then it's something we have to see if it actually needs treatment. And that usually applies then also in the brainstem. So that's why also the rebleeding rate in the brainstem is a little bit higher, because of that that eloquency, that just the smallest additional oozing can cause more symptoms than in a location where there's not so much function.
Thank you. Here's an interesting question too. You mentioned ultrasound imaging. Is that only available during surgery, since ultrasound typically isn't useful through bone? And how does the image quality of ultrasound compare to MRI?
Yeah, that's a very good question. And yeah, so that's totally correct. So it's very difficult to do ultrasound through the bone. We sometimes do this for transcranial Doppler in patients who have, for example, ruptured aneurysms to see if these vessels are spastic. So there are some windows, but obviously the ultrasound is not enough to be used to look at cavernomas on follow-ups. But intraoperatively, when the bone is taking out the portion during the craniotomy, then it's a very, very useful tool and a very user-friendly, in my perspective, not very expensive technology, and really a real-time imaging guidance for also resection control. So you can, when you remove the lesion, and you can really check that everything is out, and it is very sensitive, I have to say. Sometimes you see a little bit of blood residual, and obviously the MRI would be more sensitive, but having said that, in intraoperatively, it's very useful.
All right, I'm going to go to some questions that were mailed to us ahead of time. Someone wrote in asking to know more about your experience, like how many CCM surgeries you performed and how many of them were brain stem.
Yeah, so we probably see here at Penn, so I started in September, so I don't have a full year, but probably I would say that we see about 100 in clinic, and then just a small portion of them need actually surgery. So I would probably say 20 to 30 need then surgery personally per year probably. And then a small portion of them are brainstem cavanomas, because that's not very common, and we're, as I mentioned, if but overall we're also treating arteriovenous malformations and aneurysms. Oh, myself double.
Okay, so, but I think the question is not what's happening at Penn, it's what's happening, what's through your career. Do you have a number?
Oh.
You know, like Michael Lawton had his AVM number.
Yeah.
Do you have?
No, I don't really have all my numbers, but it's, yeah, I probably did so far around 5,000 surgeries. So, but then obviously not all cavernomas. I don't have my numbers for cavernoma specifically.
You'll get back to us on that one.
Okay.
And then the same person also wanted to know whether you had seen someone with involuntary movement and a brainstem lesion. Obviously that happens. And if so, did you treat them with surgery?
Yeah, that's a very specific question. So, sure. Sorry, I'm just hearing myself double. Yeah. Can you still hear me?
Yes, we can hear you. You're breaking up a little bit.
Okay. Okay. I mean, that's a common symptom, and it depends. You have to also see the images if this is really caused by the cavernoma, or if you can make it better with the surgery, if that's the only symptom. But it's possible that this may be a situation where you can look into surgery, but it's very hard to say without seeing any images, just based on the symptom.
Okay. Someone else is interested in what kind of hardware is left behind after surgery. People talk about having titanium screws or having other pieces of stuff that's attached to their skull or elsewhere. Can you share a little bit about what someone could expect coming out of surgery still having added or having been added to them?
Yeah, so we usually use these titanium screws and plates, and they're very small, and it's just to refixate the bone window we take out. And we do that with all brain surgeries. So it's not specifically for Cavernous, it's for brain tumors, for aneurysms, for any other lesions, and they can stay in permanently. Sometimes you feel a little screw under the skin, but they can really stay in there. They shouldn't make any noise when you travel. The airport, for example, and they're very benign. It is important to refixate the bone, otherwise it would be dangerous that this bone flap moves. So that's why we have to fixate this. But they're very low profile and can stay in there forever.
Someone else is asking, how does surgery on spinal cavernomas differ from those in the brain?
So they're similar to brainstem cavernomas in the fact that you have to be very careful to go around, because in the spinal cord there's a lot of eloquency, and you have to make sure that you're not moving too much into a healthy tissue. But then it's pretty similar from the surgical technique. Obviously the exposure, you usually approach them from the back. So when the patient is asleep, we'll turn the patient on the belly, and then we'd do a small opening in the back. And what's similar to a craniotomy, there we would do a laminectomy, where we remove part of one of the levels from the spine to get to the spinal cord. And then depending where the lesion is, usually we have to go for, exactly in the midline to make sure that we are not injuring any fibers. So it's a more delicate location, and the lesion is not as common as in the brain.
Someone asks, if you have hemorrhage from one cavernoma, does that mean you're more likely to hemorrhage from the others if you have multiple? Or do you treat each cavernoma independently versus collectively?
Yeah, especially in patients who have multiple cavernomas, I really look only into the specific symptomatic lesions. Sometimes we see actually a regression in lesions. It's possible, especially in patients with multiple. So we really look just into the single lesions. And it is interesting, it's not well understood that patients with multiple cavernomas, it's possible that one lesion grows in a year, but then the next 5 years, we don't see any growth. And then all of a sudden another lesion may grow. So it's very hard to predict. So that's why I think this is really important for us also from the research perspective to find medications to treat this kind of systemic disease, because it's not just a local disease like in the sporadic form. So, and we can't just chase every little cavernoma surgically. So I think that's really a very important indication for us to find medications in the future to help these patients.
And that leads into the next question, which is how hopeful are you and what is an estimated timeline for approved medical therapy?
Yeah, it is difficult to say. There are clinical trials right now on the way. That will take, I'm sure, a few years to know how effective they are. And right now we're looking mainly into medications who are already FDA approved, and we're using them in a different setting. So it's the question if these are really the ideal medications. I'm guessing that there will be better medications, but we still have to test them in the lab in animals before we can bring them into clinical trials. So I still think it will take a while, unfortunately.
And so then someone else is asking, do you recommend that your patients with CCMs take beta blockers given the results from some of the recent studies?
Yeah, I mean, I always say if because it's beta blocker, if there's no contraindication and we see in these early results that this may help to stabilize the disease. So I always encourage to look into this clinical trials and maybe participate in this. I think it's better to participate in these trials than doing outside a trial, but it's I have nothing against it to use a beta blocker in that situation, but it's unclear if it will help. That's the only problem. So if there are clear contraindications, obviously don't risk it to use a beta blocker. But if there are not, and in a setting of multiple cavernomas, then I would support that decision.
Someone else is asking, does the size of the lesion have an impact on the prognosis?
That's a very good question. I would say if the lesion is stable and doesn't cause any symptoms, then the size is not really a factor. But we know the larger the size, the more likely the patient will have symptoms. And then it comes back to the fact, like, where is the lesion located? And if it's really on the surface and accessible, then I think these patients have the same good prognosis for cure than smaller lesions. If it's obviously in the brainstem and very eloquent, then this has obviously a higher risk for symptoms and also for morbidity. So I think comes back again to like the specific location.
Okay. Someone is asking, what is the risk of epilepsy with cavernous angioma from surgery in the left frontal lobe? And I think that question is saying if somebody doesn't have epilepsy going in, is there a risk that they will come out with epilepsy?
It's not a high risk, but it's possible because whenever we injure the brain with surgery. So because we're taking something out, we're creating basically a little injury. It's always possible that you cause also a seizure, but it's very uncommon. I think I can't remember patients who never had a seizure and then just after surgery having then new seizures just based on the surgery. And it's possible that maybe parts of the hemosiderin may cause a seizure as well, so the hemorrhage around the cavernoma. So that's why I think it's important in areas where it's safe to take also this portion out in addition to the lesion.
And questions about birth control use in pregnancy. Is hormonal birth control something that you tell women not to use? And also, is it risky to be pregnant if you have, this person specifically asking about sporadic form, but really about any form?
Yeah, I mean, we looked into this actually in a publication with Berta Lanfi. It is possible that like the hormone changes can cause a change also in the growth of the cavernomas. So, but we would not recommend to be pregnant. I mean, we would still support the decision for pregnancy, but then we would probably do a more closer follow-up of the lesion before the pregnancy or during the pregnancy with MRI, just to make sure the lesion is not all of a sudden growing. But there are reports that there are changes with hormone therapy or with pregnancy.
Okay. Lost my place here, sorry. What percent, this might be outside of your wheelhouse here, what percentage of children with cavernous angiomas typically have symptoms? Do you know? I'm not sure I know that number.
No, also not sure.
Yeah.
But it's probably pretty similar to the numbers I showed, because I think yeah, I mean, the disease is more common in younger patients. So I think all the data we see is also covering the pediatric population.
Yeah. And also, I mean, I think I'm going to have discussion now with you and not just ask you questions, but I think that, you know, more lesions develop over time. So there are, and I know that there are doctors who have told their patients this is congenital, you were born with it, but that's not necessarily the case. So when we're looking at symptomatic over time, it could be that that kid didn't have a lesion, but then when they're 30, they do have a lesion, and that therefore that's when they become symptomatic. So the question of percentage of children with cavernous angiomas assumes that the lesion was there at a young age, whereas people are developing more. And in the hereditary forms, they obviously are developing more over time. But what we do know is that I believe the statistic is still clear that 25% of people who come to diagnosis are under the age of 18. So
yeah.
All right. Try not to hit any more stumpers. Is there a reason to believe that the COVID vaccine would affect people with CCM negatively?
No, I don't think so. I think it's very important to get the vaccination, just to make sure that you don't get COVID, and that can make it worse. And I think in every situation, not only with cavernomas, but I didn't hear about any complications in a patient who has cavernomas and received the vaccination so far.
We're almost running out of time. And Lindsay, if you could drop the link to the support group in the chat, that would be great. The one more question is there an increased risk of bleeding when taking SSRIs for depression or anxiety? And then also, what about over-the-counter NSAIDs?
Can you repeat the question?
Yes.
Sorry.
Okay.
Just
So
picking up.
risk of bleeding, they're asking about medicines. Is there an increased risk of bleeding if you're taking SSRIs or if you're taking NSAIDs? What do you share with your patients about NSAIDs and about SSRIs?
Yeah, I think it's fairly safe to take them. I just it's like the same with aspirin, for example. I mean, if it comes to a hemorrhage, then it's I mean, it's more likely that you maybe ooze more or have a larger hemorrhage than if you don't take these medications. But I don't think that it affects like the risk of actually causing a hemorrhage. So if there's an indication for the medication, I would be fine for the patient to take it. Um, but obviously, if you don't need to take it, then don't increase your risk. But I'm not necessarily saying no to that medication.
All right. I'm going to stop asking questions now. A lot of these other questions actually are pretty personal. And so this isn't the right place for that. We need folks to, if they want to find you and get an appointment, you are at the University of Pennsylvania.
Yeah.
And they can certainly head on up there, or we have other centers of excellence around the country that certainly have experts who can take care of you. There's a couple things I want to mention. So Lindsay dropped, I mentioned this at the beginning, I'll mention it again now. Lindsay dropped the link for the support group, which will start right after this ends. That link gets you, I believe, to the registration. You register, you get the link to the actual support group in your email, and then you can join and talk some more. The other thing I want to make everybody aware of is our Celebrate Together for a Cure event that's happening on August 29th, and it's a huge big deal. This is where we're hoping to have 20 to 50 different sites around the country, at whatever size and venue you're comfortable with, given where things are with COVID, but mostly what we're having right now are outdoor activities. And at the same time, we will have some video coming into you, an opportunity for the different parties to join together on a Zoom and say hello to each other. For us, it's really a time to do two things. One is to celebrate an opportunity to be together again. We have been apart for so long, it feels like. And then the second thing is to celebrate the opportunity to accelerate a cure. We have been able to really ramp up momentum. I did a whole thing in December. Go look on our YouTube channel. There's a video about accelerating a cure. But over the next year or two, you are going to really see the momentum increase. We have drugs coming into trials, and we have a very big drug pipeline, and we are going to get to a cure. It's we just got to get together and get there together. So that is part of what we're doing on August 29th. On our website on Facebook, there's lots of information about how to join us. Just sign up as a host, or you'll begin to be seeing pages where you can buy a ticket or register for an event itself if there's one happening near you. And that is what I have for this evening. Dr. Burkhardt, thank you very much. This was great. I really appreciate you taking your time, and I appreciate you having you on the CCM team. I think you're such a wonderful addition for us. So thank you.
Well, thank you so much for having me. And yeah, if you have more questions anytime.
Okay. All right. Thank you. Good night, everybody.
Good night.